for the snow.
Let's get Cheetah for that.
Are you, John, are you underneath that snow somewhere?
He's digging his way out.
Yeah, we made it. Again, let me first of all extend my appreciation to my entire team here, as well as hospital administration, for getting us through the blizzard. We did some venous cases earlier and extended my appreciation then. Remarkably, all the patients have arrived and we are good to go. We have a couple of interesting cases, a renal case and a mesenteric case for you this afternoon. My team in here with me today is Cindy Tang to my right, who is our technologist, and Megan Sunga, who is our nurse in the case today. So why don't we move forward to the next slide and present the history. So this is back one, please. So this is a 73-year-old woman with known history or suspected history of bilateral renal artery stenosis from CT extending back more than a year ago. And we've been following her, and she's had progressive atrophy of this left kidney, which started at about 10.5 centimeters and now is just under 9 centimeters. She's not had congestive heart failure. She stopped smoking about 2 years ago and has a history of coronary artery disease and MI and prior coronary stents. She's not dyslipidemic, and she does not have diabetes. So you can see she's on clonidine, toprol, losartan, and a diuretic. And despite that, her blood pressure has been running rather high. She's been on aspirin Plavix pursuant to this, as well as an anti-lipemic agent. Next slide. And despite this, we can't get her blood pressure down below these levels. Her blood pressure coming in today, although she didn't take her medications, was close to 200 systolic. And you can see there's a slight difference from the left to right arm, probably due to some superimposed arch atherosclerosis. Her GFR is preserved. Next slide. So she had some imaging advance. She had a duplex earlier, which is how we know the renal sizes. These are images from a CTA, since she has preserved renal function. And very proximally bifurcating right renal artery. I'm not sure about the severity of stenosis on that side. Certainly a very, very severe stenosis on the left side. I don't think you're going to get much more complex a lesion than this, with dense calcification at the ostium. Again, that bifid renal artery, almost not a whole lot of room to sort of land this. Progressive atrophy, you can see on the kind of axial or paraxial reconstruction how that left kidney is quite a bit smaller. And our target this morning is that left renal artery, and then if we have time, we'll interrogate the right as well. Interestingly, on duplex, the resistive index on the left side is about the same as the right, but that's characteristic that on the side of stenosis, obviously you had to have a lower resistive index than actual. Next slide. So our plan is femoral access. You know, we can do these radial or femoral, but this is our standard approach. I contemplated doing fancy stuff. We contemplated embolic protection, but the data has not borne out the benefits. Some of the Carl data shown more risk of spasm, other small vessel compromise, certainly with the urologic angioguard, which we don't have anymore. But so we've actually moved away from our position, which was frequent use of distal embolic protection, to uncommon use, only in patients with advanced and rapidly declining renal function. We're going to go ahead and get some wires here. We'll probably end up with a buddy wire. We'll need to see if we have to wire both of those bifurcation branches. Interested to know where the panel would technically approach that. We'll see if we have to pre-dilate or direct stent, to probably use the Formula 414. I know Michael Jaff was actually the PI in their FORM trial. And we may or may not use some IVUS as we go here. So that being said, let me show you the pictures we have so far. So let's go. All we've done at this point is we went ahead and we did the angiogram, and here you can see that high-grade left renal artery stenosis, and let me show subtracted. Again, the right side doesn't look too bad there. And, you know, I can imagine that certainly with duplex, where we first suspected right renal artery stenosis, that can be a little difficult to interrogate with that configuration of very proximally bifurcating renal arteries. Typically, there's a lot of infrarenal aortic atherosclerosis, so there have been approaches to selecting the renal artery, including a quick flip where you advance caudally to cranially. We want to avoid that in this case because we don't want to be scraping along that infrarenal aorta. You can see the calcification of the high-grade stenosis on the left. This is a 12-degree LAO. So
you said
we can go to live fluoro here now.
The kidney has atrophy, is that right? How big of a kidney is it?
Yeah, as we Now it's just under 9. We followed it from 10 plus over the year and a half, and it's had progressive loss. And you're probably familiar with some of the old Tollefson data. Obviously, Michael Capps and Eugene Zerler had ultrasound data showing that for more than 60% stenosis, you have a 20% per year decline in renal mass. And the Tollefson data shows that once you get to 80% stenosis, those are the patients who have up to a 10 to 20% risk of occlusion during follow-up. So it's interesting, in Carl, obviously, we didn't clearly see benefit in terms of measurable hard endpoints, but we have a jeopardized renal artery here. I mean, it's very likely this renal artery, otherwise, with its natural history, will occlude if no intervention is done. So I'm not sure that was sort of addressed in Carl. Obviously, once it occludes, we lose the opportunity to kind of easily revascularize. So
John, while you're working, I'm
so
going
I
to
have
get
here.
some. Go ahead. So
Go on.
you're using a
Just an
no-touch
RDC
technique
guide
here to telescope in?
Well, right now, this is actually, I have a Cobra through the RDC. I just want to locate this thing and get a sense if we can get coaxially aligned, and then we can sort of see if we're going to no-touch or not.
So while you're working, let me get a little bit of panel input. This looks like a very difficult renal to me. It's almost subtotally occluded, recanalized, calcified. Tony, what wires, what approach are you thinking with a vessel that looks almost subtotally occluded?
Well, I mean, the first thing is to try to get access and stay away from that big ulcer that's just below the renal artery.